your talk.
Yeah, right. So, good evening, all. I'm going to talk about cannulation during the ECMO, both in VV and VA. I don't have anything to disclose. The most important thing when we think of doing a ECMO to ensure a vascular access, because it is the point which is connecting your patient to your machine. And what is more important, that it is not only just a cannulation, but there should be an adequate flow. So, an appropriate size of cannula must be ensured to ensure adequate flow, unobstructed flow, so that we can run ECMO successfully. During the era of cardiac surgery, when ECMO was restricted to the operation theater, post cardiac surgical units, not in the ICU, the surgical approach used to be the gold standard. But as we are learning more and more, we are doing a lot of percutaneous ECMO, especially during VV ECMO, and even in emergency situation during a VE ECMO as well. And that there is also further modification in the ICU itself, where the surgical cut down is being done as a modified cervical step. And moreover, the ultrasound and echocardiography has definitely made our life simple, so that we can locate the vessel, we can assess the size of the vessel, and we see if there is a peripheral vascular disease, that also we can identify, and we can avoid those vascular access which can create a complication during the ECMO. So the question comes, where exactly we should cannulate our patients? Should be bedside, because most of the time it is an urgent situation, and sometimes it's an emergent situation when we have to initiate that. Should it be bedside, or should it be in the operating room? Both have its own advantage as well as disadvantage. Well, these patients are very sick, and they have the higher risk of collapse during the transfer. So we don't need to mobilize if we are planning to do it bedside, and it can be done very quickly. But the issue is there can be restriction, because fluoroscopy may not be easily available there, and it is not as controlled environment as in the operation room. And multiple machines are there, and the ICU bed like area is not as big as in the operation theater. When we look at the operation theater, it's a cleaner environment. Staff is well trained for assisting the procedures, but the problem is this can lead to a delay. There can be issues related with the theater availability, or availability of a surgeon, or resource utilization, which can further increase the cost of the ECMO itself. So how should be the cannula? A cannula should be of the kind where it maximizes the blood flow, and there is a minimal damage to the blood cells. And we remember this Cauchy's equation, where flow is directly proportional to the radius power 4 and inversely proportional to the length. So longer the cannula, lesser will be the flow. Wider the cannula, higher will be the flow. And these cannulas are made up of polyurethane material, which there is a wire reinforcement, so that it doesn't allow the kinking of this cannula, and since they are radio opaque, so we can identify them on X-ray itself or at the fluoroscope itself. These cannulas are coated with the biocompatible substances, so that they can there is a minimized risk of systemic inflammatory responses. And the cannula, which is draining the blood most of the time, they have the side hole as well, which can increase the turbulence, but that can definitely improve the venous return, which is important for running ECMO at a higher. In all standard books, we have seen this, the cannula size according to the weight. Depending upon weight, venous cannula should be selected and arterial cannula should be selected. But more important is that we do a echocardiographic assessment, especially when we are planning to do an arterial cannulation, because it can vary. These are the just a guide, and there can be variation, and we can select the size of the cannula as per the arterial size. When we do cannulation, it is important to remember that how much is the pressure drop. Pressure drop means the difference in the pressure when the blood is entering on one end of the cannula and it is coming out on the other end. it is usually said that the pressure drop should not be more than 100 millimeter of mercury because that will lead to a hemolysis and that needs to be monitored. And we can see here by increasing length and decreasing the diameter, there is always a more pressure drop. And if you are decreasing the length and increasing the diameter, the issues with the flows will be there. So a mid path should be selected and we should choose the appropriate size of the cannula accordingly. The cannula can be of different shape, sizes, different designs. There can be blunt tip cannula which has just a central hole, which is a return cannula. This is commonly we use for the return of the blood. In the arterial ECMO, this is an arterial cannula, and the venous ECMO, this is oxygenated blood flows. And there can be multi-stage cannula where side holes at the different stages, which can allow more and more blood to come to this cannula so that the flow is unobstructed. Number of lumen depends. If it's the dual lumen cannula, as we use at a single insertion site in ECMO, that will have the two lumens and single cannula, but otherwise we have the single lumen cannula. How do we select the cannula? This is important. In a rough estimate for an adult patient, whether it's the ECMO or ECMO, access cannula should be a 25 French with a length of 60 centimeter, and return cannula should be of 17 to 19 French. Higher the cannula, better the flow. If it is the ECMO, it can go to the femoral artery. If it is a ECMO, the return can be in the right end. Usual length from the Zephyr sternum is around 40 centimeters. So for access cannula, it should be in the IVC, hepatic part of the IVC, so that it does not collapses. But the confirmation should always be done with the echocardiogram. In cases of VVF, when we are worried about the recirculation means when the oxygenated blood is going back to the access cannula and is actually circulating the circuit, and when this proportion is higher, the oxygen saturation of the patient will drop during a VVF. For that, the two cannula, the access and return cannula, should be at least 5 to 8 centimeters long. And in cases of VA, a reperfusion cannula will be required because we are putting a cannula in the femoral artery. It's a wide bore cannula of 17 to 19 French. So for the distal limb perfusion, we have to place another 7 French cannula so that we can establish and maintain the blood flow in the distal part of the lower limb. So if you look at the VA ECMO, the cannulation can be either peripheral, which is very common in the intensive care units, and there can be central cannulation. Central cannulation is usually restricted in the patient who are post-cardiac surgical patients where it is difficult to come off from the cardiopulmonary bypass, and these patients with the same central cannulation are shifted to the intensive care unit, and once their cardiac function improves, then it can be taken. The advantage of the central cannulation is you can achieve a very good amount of, as we have a restricted flow during the peripheral ECMO, we have certain limitations, but in central ECMO, there is no problem. Another advantage is of the complete emptying of the left ventricle. And we don't have any risk of the north-south syndrome because the flow is appropriate on both sides. And the problem is, we are going to do the sternotomy. There is a more extensive procedure and there is a more risk of bleeding, infection, or even the mediastinum. And that's the reason central cannulation is restricted only to the operation theaters or during in the post-cardiac surgery. Peripheral cannulation, the most common peripheral cannulation is the femoral vein and femoral artery. Besides this, femoral vein and axillary artery are internal jugular vein, carotid artery in cases of neonates, and internal jugular vein and axillary artery can be used in adult patient where we can have a benefit of mobilizing the patient. So let's take how do we do the peripheral cannulation. The quick technique is the percutaneous cannulation using a Seldiger's technique. We are all aware that we just puncture it and we pass a guide wire. After confirming it, there is no obstruction to the passing the guide wire, and we use the serial dilators, and ultimately we place the cannula inside without any resistance. The semi-Seldiger's technique, modified Seldiger's technique, is semi-open technique, where a surgeon opens the skin and subcutaneous tissue under direct visualization of the visualization. He follows the Seldinger step. And third is the open technique, where the surgical cut down is done, and surgeon is placing the cannula after making the cut down. So let's talk one by one. This is the first technique, percutaneous VECMO. Percutaneous technique. You can see here both femoral artery and femoral vein has been punctured, and you can see here the distal perfusion cannula has also been placed. So accessing a peripheral artery or vein via the minimal invasive technique, that's a Seldinger technique, it does not require any surgical access. The skin makes a good seal so that there is a minimal risk of bleeding, which is a very common complication during a VECMO, especially from the arterial side. And there is a distal perfusion has been connected to ensure that there is a we are avoiding the risk of distal limb ischemia. How we do it? It can be done in the emergency situation. It is a very faster, but there is always a risk of vascular complication, because if there is a shear of the artery, perforation of the artery, or there is a vascular injury and bleeding, the situation will be more complicated, and putting an ECMO may be a very difficult in this situation, and probably you will lose your patient because you are not able to put the cannula and you can't initiate the. So this is the percutaneous set. You can see these red color cannula that are shorter cannula. These are the return cannula. These are blue colored cannula. This is a longer cannula, and they are multi-hole cannula. These are the access cannula, and you can see puncture needle and guide wire, and these are the serial dilators. So you start with the lesser diameter, and you can increase the diameter, and finally you can place the actual cannula to the vessel where you want to cannulate. But let's see what is the outcome of these percutaneous cannulation. There are some studies which have shown the more risk and more complication of the femoral cannulation, arterial cannulation. In all the study, patient can have a retroperitoneal hematoma. There is a risk of dissection, thrombosis, distal ischemia. Similarly, in this study, almost 88% complication occurred during the VECMO. However, the VVECMO complication was much lower, is around 12%, and most of the complications were of the vascular complication. So one should be very, very careful, especially for doing a VECMO cannulation, percutaneous. And moreover, one more important thing, that even if you do a percutaneous cannulation successfully, the repair of the artery must be done surgically. And that becomes really difficult. Those who have seen it, they can understand it very well that during the percutaneous cannulation, when we dilate the artery, there is always a shear. And it becomes difficult for a surgeon to close this hole without putting a patch. And there is always a more risk of pseudoaneurysm formation, or even sometimes they get infected and they pop up, and there's a massive bleeding in the intensive care unit or even the post-intensive care areas. This we have seen in the early phases of VA. So ultrasound guide, yes, it must be done. We have to confirm the position so that we are not making a through and through puncture through the vessel. So we can locate the artery and vein, and that will be really helpful for doing the following the Seldinger technique. Here you can see the diagrammatic picture that this is the placement of the femoral cannula, which is where the oxygenated blood is being pushed in the aorta. And this is the distal perfusion cannula, which is taking care of the distal limb perfusion. Modified Seldinger technique, which we commonly use, especially in cases of urgent and situations of the VECMO cannulation, where a vascular surgeon opens the vessel, and then they identify a vessel, and then they use a persistent suture, and then they puncture it with a needle, and they place a wire. After confirming, they use the serial dilators and finally place the cannula. And this persistent suture, they tighten it. Why it is important? Because in the initial phases, the patient is in the low cardiac output state. And because now your skin and subcutaneous pressure has gone, so once the patient cardiac output improves, there is a more risk of bleeding from the surroundings of the puncture site. So whenever there is a bleeding, we can always tighten these persistent sutures, and Once the need of ECMO is over and you are planning to decannulate, same sutures can be used for making a hole closure of the hole. So easily it can be controlled and there can be risk of bleeding can be minimized with a modified surgical step. In the paucity of time, probably I will not be able to show you the video that how we do. This is after opening under vision, all the cannulation is done in the modified surgical step. This is the open technique you can see here. In fact, one cannula has been placed openly after opening it, and you can see here another cannula has been placed where the graft has been. So this is another technique where the graft is placed so that no distal perfusion is required because the flow is maintained throughout the femoral vessel and blood. The cannula is actually placed in the graft itself rather than placing in the femoral vessel itself. So this can be a side arm graft for the femoral cannulation, or even in the axillary artery, you can see there is a cannulation. So the flow is not obstructed in the vessel itself or the limb itself. And here you can see this cannula has been placed and an axillary artery and the internal jugular cannulation has been done to achieve the EA. Here, the best thing is that a patient can be mobilized, patient can be mobile even with the use of EA. In the patients who is of the age less than 2 years, the usual cannulation technique is the carotid artery and internal jugular vein, where the carotid artery is ligated and the cannulation after the once the cannulation once the patient has been weaned, so the carotid artery has been cannulated. If a patient's weight is above 30 kg, or age is around 4 years or above, then definitely femoral vessel can be attempted. Before that, the growth of the femoral vessel is not so good that a good size of the cannula can be placed. So if the age is less than 2 years and patient is needing a ECMO, then a carotid ligation must be done. If the age is above 2 years, then the femoral cannulation can be attempted, but there is always a risk of limb ischemia. And if this is so, if you can wean quickly, you should wean. And if it is not possible, then keep monitoring. And you should establish the distal perfusion if the limb ischemia is progressing. This I have already talked about the central cannulation, that there is a better drainage. Oxygenated blood is perfusing the ascending aorta, so no risk for the loss syndrome, usually done in the post-cardiotomy, and if the patient is having a peripheral vascular disease. So we can achieve a much higher flow. LV ventic is required for the decompression of the left ventricle when there is a left ventricular distension. It can be open, it can be done surgically, or it can be percutaneously by doing atrial septum. So coming on the VV ECMO, how we cannulate for the veno-venous ECMO, it can be femoro-femoral. The commonest one is the femoral and internal jugular, or there can be dual lumen catheter at one side, that's the internal jugular. So here you can see, if you see this patient is having a on VV ECMO on the left side, left femoral vein has been cannulated because the right side was already being used for CRRT, and right internal jugular vein has been cannulated as a return cannula. Oxygenated blood is going through the right internal jugular. So here you can see it is the hepatic part of the IVC, the drainage cannula in the IVC, and the return cannula in the superior vena cava, SVCRA junction and in the right atrium. You can see here this cannula, the return cannula, and this is the tip of the access cannula. And the distance you can measure should be more than 5 centimeters, 5 to 8 centimeters, so that the risk of recirculation can be minimized. So the different combinations, it can be a femoro-femoral also. You can see here one femoral cannula, the access cannula has been placed, and the return cannula has been placed quite far, so that there is a difference between the access cannula and return cannula, and the oxygenated blood is actually pushed in the right atrium itself. At some time, a pulmonary artery can be cannulated through the internal jugular vein, so that there is no risk of recirculation, and even a rest can be given to the right ventricle, especially in cases of RV failure. So double lumen cannula, this can be a cannula where the drainage can be from the SVC as well as from the right atrium, and the return port is directed towards the tricuspid valve. So this is a single vein. There is trial field, patient can be mobilized, and there can be a bicuval drainage from SVC and IVC, and the return can be through um, the tricuspid valve. But the confirmation is very important, because if the adequate position has not been achieved, there is always a risk of recirculation. Moreover, there is a risk of perforation, so one should be very much trained while placing these cannula. And you cannot achieve a 6 or 7 liter flow. You can achieve up to 4.5 or 5 liter of flow, and definitely these cannulas are quite costly, almost 1.75, 1,75,000. So you can understand this is the outer cannula. Outer part has the uh, access port, and the central part has a return port, and which is directed towards the tricuspid valve. And these are the bicuval cannula where the SVC and IVC is draining, and after getting oxygenated, the blood is being returned back to tricuspid valve. So these are the different dual lumen cannula available: Avalon, Nova Point, and Origin, and all are kink resistant, and they are wire reinforced, and they are in the different sizes and length. They're ranging from 31, 18, 24, and 23 to 30. Cannulation failure. Whenever you are cannulating, this risk should always be in your mind, and the most trained person should try to cannulate, and you should always have a backup for the vascular surgeon, even you are doing the VV-ECMO cannulation. Because once you are not able to insert the cannula in the appropriate vessel, that means you cannot do ECMO, and patient is already at risk, so he can deteriorate, and even patient death can occur. The common reason, especially in the morbidly obese patients, are there is a CPR is in progress that becomes a bit difficult, or there is severe vascular calcification or ischemic. If the vessel has got injured, there is a risk of bleeding, massive bleeding. There is a formation of hematoma. There can be retroperitoneal hematoma, pretty common, even in the VV-ECMO, because if there is a posterior puncture of the vessel, and you do heparinize these patients on day 3 or day 4, there is a seepage of the blood, and gradually it collects in the retroperitoneal area, and you will have a certain hypotension or drop in hemoglobin. Vessels may get perforated. So one should be very careful for fixation of these cannula, and multiple catheter placement should be avoided. One should not practice this. There's more risk of infection, more risk of dislodgement, and interfering with each other. You can see here there's a vessel perforation, the cannula has gone out of the vessel. Other complications in the VECMO, there can be risk of mild ischemia. The difficult puncture may lead to a bleeding and need a blood transfusion. Vessel perforation, upper body hypoxemia, that's related with the VECMO, where you need to uh, improve the upper body oxygenation. There can be vascular complications, significant bleeding once you remove the cannula if the adequate pressure has not been applied in VV-ECMO, or there is a formation of pseudoaneurysm or rupture of these aneurysm, and wound infection, which may lead to a wound debridement. So, to conclude, appropriate and uncomplicated cannula placement is key to success for ECMO initiation. A technical improvement, especially improved cannula design, along with the use of ultrasound, as a major contributory factor for successful placement of ECMO in the intensive care unit, the cannula in the intensive care unit for ECMO initiation. But still, you should remember that the complications do happen, and we need a multidiscipline team, so that if there is a complication, there should be a backup to manage it immediately. Ultrasound is required, especially when we are doing a percutaneous cannulation. Appropriate preparation must be done. You should have adequate different sizes of cannula, not necessarily that I want to put 25, so there should be only 25. You should have other cannula as well with the adequate arrangement of blood. Insertion technique should be very careful, especially when you are doing a percutaneous cannulation. One should be adequately trained, and then only you should try this in the emergency situation. And a surveillance is very important, and most important thing, never panic, never force. When your guide wire is having resistance, never force your dilators or cannula.